at the Wilson Center to be hosting our third panel in our maternal health series that we've entitled Advancing Policy Dialogue on Maternal Health. Today's session, as I think you've probably seen, is maternal and newborn health as a priority for strengthening health systems, a topic that I think we can all agree is a very appropriate one to be having on International Women's Day. So please welcome to the center. We have, as I mentioned, this is the third meeting in a 9-part series. We have a number of terrific partners and co-conveners in this that I'd like to thank right up front: the Maternal Health Task Force, United Nations Population Fund, UNFPA, and USAID's Bureau of Global Health for technical assistance. It's been really terrific with working with all of them. These meetings are really a product of a collaboration among all of our organizations, and so it's terrific to see so many of them here today as well. I'd also like to welcome the folks who are watching online, both live and then archived down the road. We're doing more and more with trying to have viewing parties, and so welcome to those who are doing that. You can, in fact, send in questions that they'll bring up to me, and we'll try to integrate into the discussion by emailing globalhealth@woodrowwilsoncenter.org. So please join us that way as well. Next, highlight for a coming event in April. Unfortunately, we don't have the date quite nailed down, but we'll have a session on reproductive health in post-conflict settings, a related set of discussions we're having under the Global Health Initiative, and on their website you can find a number of the upcoming sessions that we'll have focusing on maternal health. So the context for today's event is that in many respects over the last few years we've been hearing a lot about maternal mortality indicators being used as a strategy for strengthening health systems. We're interested to hear more about data that might exist and how best to execute this strategy and how these indicators should be defined. So we have this kind of macro narrative, and what we want to do today is really drill down on that in order to improve health systems for maternal health. We're obviously looking at increased financing, increased research needed. And I think we have some real absolutely top-notch speakers today who can help provide some guidance and help us think through, from a policymaker, from a donor, from a program manager perspective, how to prioritize these interventions, the donor funds, and strategies for, in some sense, kind of thinking hard about these maternal mortality indicators in this context. So in the order that our guests will speak, we have the honor of 3 folks joining us. Minister Julio Frenk, who is the former Minister of Health from Mexico, now the Dean of the Harvard School of Public Health, will kick off. Terrific. Welcome, sir. Helen de Pinho is Assistant Professor of Clinical Population and Family Health at Columbia University, also the Associate Director of Averting Maternal Death and Disability Program. And finally, Agnes Soucat is the lead economist and advisor on health, nutrition, population for Africa at the World Bank and leads the Health Systems for Outcomes program of the Africa region at the bank. Those are the very short versions to very distinguished biographies that you will have been able to pick up outside. So without further ado, Mr. Frenk, turn it over to you.
Thank you. Good afternoon. Happy International Women's Day, which is today. I'd like to thank the Woodrow Wilson International Center for Scholars, the Maternal Health Task Force, and the United Nations Population Fund for inviting me to participate in this policy dialogue, which really addresses a crucial topic, and I think it is a great way to celebrate International Women's Day. As you all know, in the past few months, there's been a burst of initiatives in the global health space coming or emphasizing the need to strengthen health services as a key strategy to achieve the health-related Millennium Development Goals, including, of course, very centrally, the reduction of maternal mortality. This is a very, very good development, the interest in health systems. However, we should acknowledge that there's no agreed-upon consensus on how best to achieve the goal of improving health systems. So what I'd like to discuss today, and what I was asked to discuss today, is what's being called the diagonal strategy. And this is just an extension of the geometric metaphor from the traditional divide in the health community, the public health community, between the vertical approach that focuses on specific disease priorities and therefore is very focused on achieving results, but at the same time may lose sight of other priorities or may lead to an inefficient multiplication of efforts, versus the horizontal approach, which looks at strengthening the general aspects of the health system, but very often without paying attention to specific priorities, which in many countries then leads to strengthening strategies that systematically forget about those health problems that affect the poorest parts of society. And because of the shortcomings of both approaches, my colleague Jaime Sepúlveda coined the idea, the notion of a diagonal strategy that tries to bring together both of these strands of thought. And the basic idea is to have clearly defined priorities, but to use those priorities to drive general improvements in the health system. And I like to then use the case of particular maternal and newborn health, but more broadly the construct of women and health as an example of how we can implement that. And I will mostly use examples, real-life examples from my own country, from Mexico, and from the large-scale reform that was carried out there starting in the year 2003. I think the key message of my presentation is very beautifully captured in the motto of the Wilson Center, knowledge in the public service. And this is exactly what I like to elaborate when I describe particularly the reform in Mexico. So what I like to do is basically cover three main topics. One, just to first set the global context, particularly when it comes to women's concern. Then, second, try to focus more specifically on a novel approach, I would say, around the construct of women and health, not women's health, but women and health. And then finally use the case of Mexico to illustrate some of these concepts. So let me start just briefly with the context. The world is in the midst of one of the most intense health transitions in human history. There's been a major shift characterized first by a pretty substantial decline in general levels of mortality. The human species achieved a higher improvement in life expectancy during the 20th century than in all its previously accumulated history. At the same time, the dominant patterns of death, disease, and disability have changed, and the whole meaning of disease has changed from patterns that were dominated by a succession of acute episodes where people got sick from something and either you recovered or died, only then to move to the next episode, to disease being a condition of living, as more and more chronic conditions dominate the picture. A condition of living that's very often stigmatized. And I think it's this element of chronicity more than whether it's communicable or not communicable that is important. There are chronic communicable diseases. The obvious example is AIDS. The interesting feature, and what I like to emphasize as a growing level of complexity, is the notion that in developing countries, these different patterns coexist. There's a very different path if you compare currently developed countries with currently developing countries. Currently developed countries had a pattern of substitution, where new problems substituted for old ones. Developing countries have a pattern of juxtaposition. So most countries today are experiencing a triple burden of disease, a huge unfinished agenda of common infections, malnutrition, and reproductive health problems, very centrally maternal mortality. Without having dealt with that, already most of these countries are facing the second burden, which is the emerging problems represented by non-communicable diseases and injury, including violence, and I'll mention that that's a very relevant part of the agenda on women and health. And then if all of that was not enough, then we have a number of health problems that are directly related to globalization, like pandemics, like the current pandemic of H1N1, that come and on top of our already strained health systems, then add a new set of demands, or the international transfer of lifestyles that's leading to the worldwide epidemic of obesity and other problems. So it's against its backdrop that I think we can analyze the main challenges in terms of women and health. And as you know, some of the concepts have been evolving, obviously through almost initial focus or exclusive focus on maternal issues, through the 1980s and 1990s, a focus that expanded into the construct of reproductive health, very much associated with the Cairo and Beijing conferences, an expansion into women's health. And what I'd like to propose is a comprehensive concept of women and health, which we actually carried out in Mexico during the years of the reform. And to explain this, picture a number of concentric circles. The core of those concentric circles have to do with maternal mortality and disability, the prevention of maternal mortality and disability. The second circle are other aspects of sexual and reproductive health in addition to those related to pregnancy and delivery. Then you have a third circle of women's health proper, which are other aspects in a life course perspective affecting the health of girls and women through the life course, in addition to those related to sexual and reproductive health. And then the final construct is women and health, which includes all of the previous ones, but in addition addresses some fundamental topics of the intersection of women with the health system, the topic we're addressing today, like women as main providers of care in the home, and with these big trends towards a growth in chronic diseases, the burden of the domestic production of services and the failure of formal health systems to provide support, that burden falls disproportionately on women, and then is added already to general domestic work, working out in the labor force. Then you have this added burden of taking care of someone who's chronically ill in the household. By the way, this fits back to the circle on women's health, because the stress of caring for chronically ill persons is a major source itself of stress on the caretaker. Second topic, women as members of the formal health workforce, not just the traditional gender divide between nursing and medicine, but an increasingly feminized workforce and all the implications, not just in terms of opportunities, educational opportunities, but also occupational opportunities. And then lastly, in general, a gender perspective that addresses or applies a gender focus to all kinds of issues, from the differential responsiveness of the health system and the differential levels of quality to the way we even report health information without clear disaggregation by sex. So this is the framework, very briefly, that I like to propose, and that was actually carried out in the course of a comprehensive effort at health reform that was carried out, that's still underway, but was begun with a major legislative reform that happened in Mexico in 2003. Let me give you in a nutshell what that reform was about. I'm not going to spend time on that because I'd rather engage in the conversation later on and through questions and answers. And furthermore, this reform has been very widely documented. There was a series of 7 papers in The Lancet, and there's been a very, very large literature since it was a very carefully evaluated reform. But the basic idea was to establish a universal system of social protection in health to assure access to high-quality services with financial protection for everyone. Mexico, like many countries in the world, both poor and rich, among the rich is the country where we are standing right now, had a substantial part of its population without any insurance or any other form of protection against the financial consequences of illness. And through very, very precise evidence-gathering exercises, it was possible to document that more than half of all health expenditures were out of pocket due to the fact that more than half of the population lacked health insurance. Mexico has about 100 million people, so that meant 50 million people without insurance. And that led to a huge number, about 4 million families every year, that incurred catastrophic expenditures, and to what I've called the unacceptable paradox, namely that today we know that health, improving health, is one of the most powerful tools we have to empower people to lift themselves out of poverty. Yet health, or paying for health, can itself become a major source of impoverishment when a country lacks universal protection to all its citizens. And that's exactly what was happening in the United States. Health is the single most important cause of bankruptcy, both for family and businesses. And WHO estimates about 100 million families in the world who every year go broke because they got sick. And that was exactly the situation we were trying to prevent. But doing that in a comprehensive way. Now, this structural reform required a flagship initiative. And the flagship initiative was built around this concept of women and health that I just explained through the concentric circles. So the idea was, how do you relate some of these measures and relatively abstract financial and organizational concepts like social protection, quality of care, access, infrastructure development, to concrete deliverables? And we found that among others, AIDS was another one, but among others, the notions around women and health was a very powerful way of both illustrating the content of the reform, proposing to both to the Congress and to the public a very explicit set of priorities, and then driving the reform in a clear illustration of the diagonal strategy. So let me just finish by telling you how we did that. So first, every single aspect of this complex reform was looked at through the lens of women and health. So for example, in designing the benefit package, a central tool of any insurance, public insurance or social insurance program, it was very clear that every single one of the interventions that can proven to have great value had to be included, but not just the standard interventions for basic care. The reform also included a fund for protection against catastrophic expenditures. So things like cancer, cervical cancer, breast cancer were also included. Second, even all the measures for quality improvement were again driven through this lens. Even the regulatory activities of the Ministry of Health were motivated by the agenda of women and health. So that, for example, every maternal death triggered an audit, an investigation, and could lead even to a hospital losing its license to operate if that investigation concluded that there were major flaws. So the quality assurance component was driven mostly by the goal of reducing maternal and neonatal deaths. The improvement of the health information system was initially triggered by an effort to actually get the number of maternal deaths right, which, as you all know, is a very not a trivial thing to achieve. So this just illustrates how you can take a specific set of priorities and drive them through. And let me illustrate that with the various circles I talked about. First circle is the reduction of maternal and newborn mortality. We launched the flagship initiative, which was called Fair Start in Life, basically with the idea of reducing that, and then allocating specific budgets to strengthening healthcare networks, doing the necessary investments in equipment, in the supply of drugs, in creating the emergency networks to be able to deal with obstetric emergencies. And some of the results that have been shown in some of the evaluations do show not just a greater utilization of prenatal care, a greater coverage by skilled birth attendants, but also, which now reaches about 93% of births, but most importantly, a significant acceleration in the rate of decline of maternal mortality. Still not enough, but a very significant acceleration of the rate of decline. But this was clearly not enough. There were other aspects of sexual and reproductive health that needed to be included, and that was the second circle. I won't go into any detail, just to let you know that a big part of that was, of course, providing the means for women to control their own fertility, and that meant a thorough revision of the family planning policy and norms, which included emergency contraception. And I would say this was probably the most interesting part of my tenure as Minister of Health, because in predominantly Catholic country, getting that through and approved was a very interesting exercise. But it was done because of civil society mobilization and because of the mobilization of evidence. The evidence was so strong against the claims that the morning after pill would promote abortions, and rather to the contrary, was so strong that this was probably one of the best means to stop unwanted pregnancies and therefore reduce the demand for abortions, or the incidence of abortions, that in the end the power of evidence did carry the day in a very, very public and polarized debate, along with the mobilization of civil society, particularly women's organizations. And then we moved to the third circle, and particularly looking at other aspects in this complex epidemiologic transition. And I think two stand out: violence against women, again, a number of very interesting innovations that came out through a very thorough survey, and the problem of cancer-related deaths, both cervical cancer, but also breast cancer, which turned out, as we were able to, over many years, reduce the incidence of the mortality rate from cervical cancer. Breast cancer was creeping up, and today actually there are more deaths from breast cancer than from cervical cancer. And this is a priority that has not been fully recognized, but it's a key part of the epidemiologic transition. The new insurance schemes includes coverage for mammography, of course, for pap smears, both of which have grown significantly, and also for what you do once you detect it, which is the need to have access to treatment. Finally, the last circle, women and health. And that involved the need to establish, as we did, a whole gender perspective around every part of health policy, including which led to the creation of a National Center for Gender Equity and Reproductive Health at the Ministry of Health, which allowed the adoption of a gender perspective as a cross-cutting policy, the design of gender-sensitive budget, the generation of health information disaggregated for sex, and the surveillance of gender biases in access to health services, in the quality of care, and in the responsiveness of health services to the differential responsiveness to women and men. Let me finish by coming back to my image of the concentric circles around women and health. It is a very powerful image because, as many of you are aware, in many cultures, it actually represents the womb of Mother Earth, and it is related to the ideas of support and integration. And I think what global health needs now is to get out of the traditional confines that have split the community between vertical and horizontal, communicable and non-communicable, and actually adopt more integrated frameworks like the notion of women and health, and the notion of using a diagonal strategy that identifies clear priority and then uses that to drive those improvements that will then leave behind a strengthened health system there in place, so that if we are actually successful, we will have a better health system to deal exactly with the next challenge that faces us. Thank you very much.
Good afternoon, everybody. And first of all, to remind ourselves of why we're here on National Women's Day, to thank the Woodrow Wilson Centre very much for this opportunity, the Maternal Health Task Force, UNFPA, and also to acknowledge my colleagues in AMDD. I really and specifically want to acknowledge Patsy Bailey, Samantha Lobus, and Lynn Friedman, who are really the key thinkers around this idea of how do we begin to use the maternal health indicators to strengthen health systems. And I really want to thank Dr. Frenk very much for setting up this idea that we can go beyond just a very narrow vertical program of maternal health, because maternal health actually doesn't work very well as a narrow vertical program. It is by its very nature embedded within the health system. And I think it's important that we spend a few minutes on this day looking at what is the health system doing for women, for people in general. And much of that was mentioned earlier. Those people who need health most are not getting it. Inverse care rule applies. It's impoverishing people, as was mentioned. 100 million people go into debt, go and become bankrupt every year because of the way that the health system itself is structured. It's fragmented and fragmenting. We've all experienced the hyper-specialization of healthcare in this country. But when you go down to the services on the ground and a woman has to walk X number of miles one day to get her antenatal care, come back the next day for her child health, then we have a problem. We know too that in many instances it's the quality of care provided is unsafe, it's poor, and often is misdirected, that the priorities in many of the countries that we work in now have become skewed for various reasons. We all like to blame the big AIDS skewing of donor funding, but it's not only about that, it's political skewing. So what are we actually needing to look at when we talk about strengthening health systems is that we need a health system that now is responsive to people's needs to actually deliver the outcomes that are necessary, but also that is efficient, that is protective of people, and that it delivers effective care, it's available to people. So WHO has operationalized these ideas through the Framework for Strengthening Health Systems. And they talk about these 6 elements as core to developing a strong health system. And what I'd like to do this afternoon, in the time that I have available, is to take these and look at to what extent are the maternal health indicators that we are using out there applicable and can be used to talk to some of these issues. How services are delivered. Is the workforce correct? Is it there? Are there people available? Are they appropriately trained? Is the skill mix correct? Is there timely decision? Is there timely information for decision making? Is there any information for decision making? Some of us might ask. Are there drugs and supplies and logistics, and are these appropriate? And what are the systems to get them? And does everyone have access? Are the financial systems adequate, and are they protective so that people are able to access care and not fall through the holes in the safety nets? And finally, what kind of leadership and governance exist? Are the policies that are being developed appropriate? We heard about Mexico's appropriate policies. What is happening in other countries? And so I would like to take a little bit of time to say, well, what do health systems for maternal mortality reduction, in particular maternal and newborn mortality reduction, look like? What is needed? And how then, as we measure these, could they contribute to the strengthening of health systems through some of these mechanisms? I was sort of assuming, I haven't got the usual slide which says 500,000 women die every year as a result of pregnancy-related complications, because I'm assuming you know that, and I see nodding of heads. I think we also know now that what are the 5 major causes of the direct obstetric complications. And we also know that no longer can we depend on the risk approach to identifying those women who are at risk. We do know that most maternal deaths can be treated and they can't be predicted and prevented. So we need a health system that is responsive, that is there 24/7, that can get women to definitive treatment in the kind of time that is needed from the onset of the complication to death. And often that time is very short, depending on their death. For newborns, we also know that much of the newborn death is occurring within the first 24 hours. So time is of the essence. And Dr. Amaswa, previous head of the Global Health Workforce Alliance, once said, if the health system can function to get a woman in rural Uganda who develops eclampsia in a rural clinic to a hospital that can provide the definitive treatment in the time necessary, that place has a functioning health system. Recently, in the space of the safe motherhood history, very recently, there was finally a consensus on what are the core interventions and strategies for reducing maternal and newborn deaths. And we recognize a continuum of care from home to hospital. And this, all you need to know about this, it's a continuum of care with a focus on 3 major strategies: access to comprehensive family planning, skilled birth attendants, and access to emergency obstetric care, and access to safe abortion where legal. And they estimate that as a result, if that was to be implemented, then we would look at 1 million lives saved of women who may have died, women and children dying from complications, 4.5 million newborns, 1.5 million stillbirths, and this begins to add up more than the combined deaths of people dying from AIDS, TB, and malaria every year. So there's a real need to focus on this. Many of you are aware that for many years, Averting Maternal Death and Disability Program, AMDD, in collaboration with UNICEF and UNFPA, worked to develop what was previously called the UN Process Indicators and are now known as the EMOC indicators. And in our work, we supported and worked and partnered to complete 42 national and near-national needs assessments. And really, I put this up there, said that there's a long history to looking at how to assess the development of health systems that will respond to the things that we know need to be done to reduce maternal mortality in the absence, as has been said already today, of the very difficult task of measuring maternal deaths. So recognizing that actually measuring maternal deaths is very difficult, how do we begin to monitor the strengthening of those services? I'm going to run through very quickly, you'll be pleased to know, some of these indicators and look at how they relate to the WHO Health Strengthening Program. These indicators are generally measured nationally. Increasingly, we're seeing that they are integrated into the health measurement information systems, that they're also used as project monitoring. And they really talk to 3 big issues. What is the availability of services for maternal and newborns? What is the utilization, the quality care, and what else is needed? And you already begin to get this idea that these talk straight to the building blocks. Let's just have a quick run through, and many of you, I'm sure, are familiar with these. The first one is obvious. Are there enough facilities providing emergency obstetric care? What do we know about, is the service there should women, when women need them as they develop obstetric complications? And this is based on identifying whether these services provide the core signal functions. And we've elaborated 9 signal functions, which if the comprehensive service that provides these 9 functions, if the signal functions are present, then you have a good chance of actually treating the set of complications that cause the direct obstetric complications. And these are divided into 7 signal functions for basic emergency obstetric care, which address whether there's sepsis, whether there's prolonged labor, how to manage eclampsia, how to manage hemorrhage, and also looking at blood transfusion, and finally neonatal resuscitation. These signal functions, when conducting the needs assessment, are not theoretical. You actually go into the services, and they're a construct of a number of elements. The signal function is only said, the facility that you're looking at is only said to provide those signal functions. If the staffing are there, that they're trained to provide these functions, that they have provided them in the last 3 months, more than a longer time than that, and you start to wonder whether they're capable of providing it, whether there's sufficient cases, whether the drugs in supply necessary to provide parental antibiotics or the eutonic drugs or even for assisted vaginal deliveries, whether that equipment is in place, and whether the policies support that. And if those aren't available, that signal function is not happening, that's not an emergency obstetric care facility. So a simple assessment of is this an emergency obstetric care facility, combines a number of aspects that are core to strong health systems. Is that workforce there? Are those drugs there? Is it actually responding to the needs of the woman when they need it? Some data from the project in one province in Mozambique, from Sofala, and this was a project we worked with UNFPA. And you'll see that on the left-hand side of this, your right-hand side of the screen, the recommended number for their population of basic emergency obstetric care facilities in Sofala was 13 and 3 comprehensive. And when we started working with UNFPA, while the total number of facilities was more than adequate, we found that there was sufficient comprehensive emergency obstetric care facilities, but no facilities capable of providing basic emergency obstetric care. So this did not require building new services over the year, it did not require building new clinics, but it certainly meant just upgrading services, paying attention to the health workers, ensuring that the signal functions were able to be delivered at those services. I think a very important question that we often get asked is why the split between basic and comprehensive? Why is it a problem if all 16 services were comprehensive emergency obstetric care? I think this goes to the heart of whether this is efficient, and is this an efficient use of health resources? Because much of the emergency obstetric care can be managed at a health centre level. So we shouldn't be wasting resources at a hospital where we know things are more pricey if they can be done at health centre. Are they well distributed? And this goes to the heart of the equity. We know the sort of tyranny of the aggregate. You can aggregate everything and it looks good. But at subnational levels, what are we seeing? In Bhutan, in 2000, when we did an assessment of the emergency obstetric care facilities, we found that there were 4 emergency obstetric care basic centres and 4 comprehensive emergency obstetric care. And in fact, that almost met Bhutan's needs. But you can see the distribution between March 2000 and March 2002 was quite significantly changed with a broader distribution. And an interesting there is that often in these assessments we include the private sector because much of comprehensive care is provided by the private sector in Bhutan, a very mountainous country, so this distribution was appropriate. Similarly, in Angola, the recent needs assessment showed that there was only the country only met 25% of its recommended minimum number of EMOC facilities, but the range amongst the different provinces was significant, ranging from an oversupply in the Zaire and 72% in the Lunda provinces, right down to 0 in some of the provinces. So again, a real important, if we're looking at health systems, and these are not just EMOC facilities that would only deliver maternal health care, but they would be able to respond to 24/7 emergencies in those areas, the importance of subnational. And more recently, with more sophisticated GPS measurements, we are now able to do this using GIS mapping. And this has become extremely helpful, not only in Ethiopia for actually identifying where the services were, and a couple of new ones were discovered, but also mapping these against existing roads and procurement and various terrain issues. So again, this talks directly to if you're even monitoring for emergency obstetric care facilities, you're at the same time looking at what is happening within the health system. there are two or three indicators that really look at utilization. And the first one is looking at the percentage of births in the facilities, and particularly the percentage of births that are happening within emergency obstetric care facilities. So it's not, and we recommend that this is broken up into a analysis that is the percentage of birth in EMOC facilities, and another analysis that looks at the percentage of expected births in facilities, which goes to institutional delivery rate, which is increasingly being used in some of the results-based financing mechanisms. Countries are asked to set their own levels. Some of you who may recognize this from before, they were level set, they just got very confusing. And it really does go to this, trying to understand and get a measure on whether women are actually using services. Are they actually coming to the services? And then triggers, if this is really low, special studies or further investigations as to why are women not using the service. In work that AMDD supported, led by Dr. Margaret Crook, who presented here some time back, I know she looked at the reasons why women don't use a service and was really trying to unpack why in Tanzania 46% of women will deliver in a service, although over 90% will have gone to the service for antenatal care. And what we're really seeing is that women are making a conscious decision not to go to an inadequate service. It's not for lack of knowledge, it's not, sometimes not even for lack of money or transport. They're just not going to go to a bad service, which sort of makes sense to all of us, and some of you are nodding. But, so I think that this indicator is a very important one as we try and understand, what's driving utilization. And here you have this is a proportion of births in emergency obstetric care and all facilities in Nicaragua, which gives you an idea of the breakdown. The dark blue is in emergency obstetric care facilities, topped by the green. So under 40% of births are happening in facilities where there's at least basic emergency obstetric care. Perhaps the most, that indicator that most closely aligns with maternal mortality is this idea of whether those women who need to use the services are accessing the services. And this is really met need for emergency obstetric care, looking at the proportion of women with complications who are treated in the emergency obstetric care facilities, where a minimum acceptable level is 100%. And this is really the crux of it. If you have women who have complications and are not delivering in services that could have actually managed and treated their services, then this is a disservice and really a sort of, against her basic human right for maternal health care. And again, in the work that we did in Mozambique, in Sofala province, we saw that met need increased from just on 10% to up to 30%. And remember, this wasn't with the building of new services. It was with the improvement and strengthening of what was already existing on the ground. Some data, I'm afraid, I'm not allowed to identify because it's still in process. But I think here, where you see met need in one particular sub-Saharan African country, again, on the importance of breaking this down to a sub-national level. So each one of these bars represents a region. And so the national met need is under 20%. But this is really, this is particularly high, driven by high rates of met need in some of the sort of more urban areas. But in most of the province, met need is even as low as about 2 to 3%. In other words, only 3% of women in those provinces who develop complications are actually being delivered in services that could treat them. And I think this is a really important sort of thing to keep in our minds. Another indicator is really around caesarean section rates, and this has really generated a lot of discussion on what is the acceptable caesarean section rate. So it's really what are the number of C-sections that are performed in EMOC facilities over the total expected live births. And while there is a lot of debate about what should be the the level, so the acceptable level somewhere between 5 and 15%, we do know that in many developing countries, particularly in sub-Saharan Africa, that rate is less than 5%. So even for absolute maternal indications, women are not getting life-saving care, without which they will die. We also know that the 15% is really should be what is the maximum, so that 50% doesn't mean that we're doing even better. But again, if you're coming up with caesarean section rates of 50%, that should be triggering something going wrong in that health system that needs further investigation. Again, in a more recent study somewhere in sub-Saharan Africa, the average caesarean section rate was 0.6%. So you know that the services are just not there. All right, quality of care. Here, this is the only facility-based indicator that has been developed as part of this package of indicators, which is the direct obstetric case fatality rate, the number of deaths amongst women who are admitted with particular direct obstetric complications with an acceptable level of 1%, with the argument that women who actually get into the services should be able to survive. Now, there are many reasons why this rate may be high. Part of it is to do with quality of care. Part of it is to do with the referral system. How easy was it for her to get into that service? And so these are really, as they are, indicators. They flag something going on in that health system that could be and should be further investigated. These were results from AMDD's work and with partners in Rwanda, Tanzania, and Mozambique, and what happened with direct obstetric case fatality rates over a period of 6 years as the project. 5 to 6 years as a project, and we saw significant decreases in those rates. There are two new indicators I'm just going to touch on. One is the intrapartum very early neonatal death, and that's recently been introduced, recognizing that we need to be measuring something around newborns and fresh stillbirths and really understanding better how to interpret those results. And there's still a lot of work around how to benchmark this, but it's in there so that people begin to measure that. And those rates vary amongst different countries. And the last one is because in many parts of sub-Saharan Africa, we also acknowledge that, well, what other services are needed for maternal health care? It's not just about direct obstetric death. And so we're looking at causes of indirect causes because of the high rates of HIV in particular related maternal deaths. And I think as we're talking about the diagonal approach, we've sort of, certainly at Columbia University, beginning to talk about, well, if we combined the HIV, which is really becoming a chronic care health system, and focused on HIV and on maternal health system, and really focused on getting the health system to work for chronic care and HIV, emergency care in maternal health, then you move from these kind of centers of excellence, as Gerrit Ooms has said, these kinds of islands of that begin to coalesce and form strong health systems. There are other ways of assessing, using maternal data to look at health, the other maternal health indicators, which directly look at outcomes. Mention was made earlier of use of maternal death reviews and audits, of confidential inquiries, and these are really important to be done both at facility and country level, and it really brings into play that only if action is taken and the audit cycle is completed do these make sense. That if you're just simply doing maternal audits and you've just got shopping lists of what needs to be done, they really are, we found in some of the work they've been doing, somewhat discouraging for those people who are engaged in them, but definitely something to be used. There's a lot more work now being done on the notion of a near-miss a severe maternal morbidity, a severe acute maternal morbidity, because these are more common than maternal deaths and provide some way of getting at whether the health system as it is strengthened is actually having an impact on outcome. How has all of this data been used? I think it becomes obvious that it's been used in ways that move beyond the health system, for policy, for human resource policy. A lot of my work at the moment is looking at human resources and the use of non-physician clinicians to provide life-saving emergency obstetric care. On programming, and it's been amazing to see how, with the needs assessment, how it coalesces both all the different sectors within the government to come together to understand how can we improve the road system to that clinic? What will it take to get water to those services? Can we convince the cellular providers, the cellular telephone providers, that this is how they need to plant their next, what do we call it, satellite? Well, not satellite, pylon power thing. And certainly in Ethiopia, where the most recent emergency obstetric care needs assessment is being completed, has formed the needs assessment with these indicators has been important both at regional level, but also at national level with the development partners, and in particular the H4 development partners coming together to develop a work plan based on the needs assessment. So it is that platform, those indicators when taken together, to paint a picture of and indicate very clearly where the next steps need to be taken. So I think I've worked through many of these needs, linking the needs assessment to the WHO's health system strengthening indicators. And I think finally, there are some challenges still. And I think one of the challenges, and something that was spoken about a little earlier, is how do we make these indicators available to the civil society to hold governments and leaders accountable for strengthening maternal health systems, but certainly strengthening health systems. What are those sets of indicators that can be used at that level, and what are the indicators to show that this is successfully happening? And I think obviously we're all wanting to see how do we better measure the impact of these strengthened health systems in a more timely fashion. So I'd like to thank you for your time. Thank you.
Helen, if you'd like, she's using PowerPoint too. If you'd like to take her seat so you can see the screen.
Oh, that would be good. Thank you.
How you correct on this? Yeah. Thank you very much. Thank you very much for inviting me to this very important meeting today. I'm also very honored to be here and to celebrate this particular day. And I have the very dangerous privilege to be the one who's going to talk about money. And I'm not sure what your appetite is for a series of more PowerPoint slides, but we'll try to slide through this together. Talking about money, I just want to make just a point that what I'm going to present to you is the product of a conversation that is currently taking place in the Africa region, and particularly as part of a consortium of agencies which call themselves Harmonization for Health in Africa, and basically include the UN agencies, UNICEF, UNFPA, UNAIDS, but also the Development Bank, African Development Bank, and the World Bank, and has been recently joined by USAID. And we try to basically have this conversation, and some of what I'm going to present is actually the basis of a dialogue we are having with ministers of finance in Africa, which hopefully will culminate in a conference with those ministers end of 2010. So basically, 3 topics I'm going to touch upon. I'm going to rapidly talk about more or more and better health, better money, and where are we today, particularly in Africa. And then I'm going to talk about a particularly interesting case, sort of an outlier that is currently Rwanda, a small country in Central Africa, which has pioneered very interesting innovations in terms of health financing, sort of pushed the frontier of what we thought was possible to do in terms of pro-poor health financings in sub-Saharan Africa. And then maybe conclude together about what does it mean and how can we move forward, particularly in promoting pro-poor financing mechanism that both strengthen health systems and deliver results for women, among others. So maternal mortality remains very high in SSA. I probably not telling you much there. This is the region where maternal mortality is still the highest, and with some countries which still are at natural rate of mortality. So basically, there are no health services, and they do close to nothing. Most countries in SSA are off track to reach MDG 5. This is the last bar. You see that most of the countries are seriously off track. We're not the only region, but South Asia too, but it doesn't really give us a lot of comfort. When it comes to financing, most sub-Saharan African countries spend less than $50 per capita on health, and you see that there is a very large variation. Yes, South Africa or Seychelles spend close to 400, but when you reach Ethiopia, you are at $7 per capita. Everything, public, private, donor, in 2005. Some countries, I mean, Ethiopia comes to mind, but probably close to 70% of the countries in sub-Saharan Africa have problems accommodating even the most basic package of services, the $35 basic package of the Commission of Macroeconomics and Health. More than half of health expenditures are private, and that is often forgotten or not known. While in some regions, thinking Europe and Central Asia or Latin America, public financing is a very large share of expenditures. In Africa, it's not as bad as South Asia, but yet half of the financing in those very poor countries come out of pocket. And there are actually a lot of countries where it's much more than half. Again, here the distribution is very, very broad. And what is even more worrying is almost none of these expenditures are pooled. So it's not that you have private expenditures because you have social insurance or some kind of pooling mechanism. It's just people pay out of pocket. And that's 80% of those private expenditures are out of pocket. What is really also specific to sub-Saharan Africa is that external aid is an important source of funding. And that makes sub-Saharan Africa different from the other region. Even if you have very low-income countries with a lot of poor people, like in India or Bangladesh, those countries are not really dependent from donor financing, are pretty much deciding their own fate when it comes to decisions on what to fund from the public purse. But when we talk about sub-Saharan Africa, we're still getting close to 20% of health financing coming from donors. So donors are a very important critical partner. So where does it bring us? Well, the MDG horizon is 6 years away, so it's not that long to affect a problem as entrenched as maternal mortality and low access to reproductive health. So a key question when we talk to government and particularly ministries of finance is what are the low-hanging fruits? What is it that we can reach within those 6 years? What is most effective? What can be quickly scaled up? There's really this question also that the health sector is generally perceived as not producing results. Financiers are usually very frustrated with the health sector, while they see the education sector, making a clear link between number of students in schools or exam rates and financing, they have much harder time understanding what is it that happens when they give money to the health sector, and actually articulating those results and being able to articulate them in some kind of political message if they want to be re-elected or if they want to stick to power through any other mean. So why is it? It doesn't need to be so. We all know that some countries are doing much better than others. I mean, we all know the classics, the Kerala, the Sri Lanka, the Cuba. And in Africa, we do have those. We have Eritrea, which is an incredible outlier, very low-income country, which one of the lowest under 5 mortality and best health indicators in the regions. In the region, we have countries like Mozambique and Tanzania who are doing quite well. And then we have countries like Nigeria that are doing spectacularly badly in comparison with their income and general health expenditures. Some countries give very little priority to health. Why? Is it because it doesn't produce results, or is it because citizens have no voice? What needs to be addressed? These are the key questions we need to answer. So we try to look at really what are the 5 key questions that need to be profoundly addressed by governments, particularly by ministries of finance. And here they are the ones that we've identified jointly with a couple of countries. First, I mean, the fragmentation and the fact that donors' processes are disconnected from country processes. This 20% of donor funding often comes at odds with what countries see as priorities. Second, and that's something that we talk a lot in the international community, is planning and budgeting is not based on evidence. We know that the whole movement of evidence-based medicine or buying outcomes, purchasing results is actually quite new in healthcare. And there is little analysis of what are the country-specific constraints to delivering high-impact interventions, those interventions that we know are going to get us closer to the MDGs. Public money benefit richer groups, also a large literature on that, benefit incidence analysis. Even when governments put a lot of money in health, the richer groups are very quick in capturing that. I mean, this is the large hospitals in the urban areas. This is the clinical care. Even the HIV earmark money, when we do benefit incidence analysis, we see is captured by the more urban, more educated elite, which was not necessarily the intention of the donor community when raising these funds. Public financial management is a major issue. We also have huge evidence we call public expenditure tracking surveys that actually the money doesn't reach the front line. We have this also very dramatic results in Chad, which have been published in the Journal of African Economics, which show that 95 out of $100 allocated to the health sector in Chad, $95 never reach the service delivery point. So it's only $5 out of 100 that actually get to any kind of service delivery. And what we see increasingly also is that the sort of post-colonial civil service models, most countries have adopted a Soviet model with civil servants actually delivering services, but they were mostly delivering services in urban areas for the elite, really reached the limits when we start talking about delivering services in rural areas. There you find very few civil servants and very few service delivery. So you really have a dramatic lack of linkage between performance and incentives. So a little bit of hope, because we wouldn't want to stop here and then go back and cry, is trying to talk about one country which, as I mentioned at the beginning, to our view has really taught us a lot. And I think Rwanda has really helped us basically push away any idea of Afro-pessimism and get a lot of us, the so-called experts, to really question what we were thinking about what Africa could do or not do. And I'll show a bit of what Rwanda has done over the last few years. So Rwanda is a small country. Most of you know about the genocide that took place in 1994, killed a sixth of its population, more than 1 million people died. And this is a typical African country: high infant mortality, high child mortality, a lot of malaria, malnutrition. And when it comes to maternal health, less than 40% of women actually going to facilities for delivery. And this was the case before the genocide. It was the case after the genocide. So 60% of women just not using maternal health services. And an HIV situation which is pretty typical of sub-Saharan Africa, which is basically between 3 and 5% of the total population. Again, typical problems when it comes to health system. If we talk about the pillars of WHO, very few human resources for health, 1 doctor for 50,000 people, no cash resources in health facilities, health centers, health hospitals, had never seen any money coming from the government ever. Low levels of productivity, low motivation, and of course, very poor quality of services and very low utilization generally. And yet, Rwanda has undertaken major reforms, let's say between 2000 and 2010, to strengthen the accountability of institutions and individual actors for MDGs-related results, and particularly maternal health. And it's basically talking about a shift of paradigm. It's really going away from this post-colonial model and moving around basically 5 key pillars of reform. First was fiscal decentralization, which a very strong community participation, basically the money being sent to the periphery. Contracts, and this is a Rwandan name that is used for a contract between the President of the Republic and the mayors and districts, which is called imihigo. So it's basically performance-based budgeting. Performance-based financing, which is transferring money based on results to health facilities. Community health insurance to increase access from the demand side and reduce the impact of out-of-pocket spending and catastrophic expenditures. And finally, autonomy of health facilities, including the hiring and firing of health personnel by those. So the way we sort of summarize this is using the triangle that some of you know from the World Development Report 2004, the accountability triangle, which is basically the heart of the reform is to increase accountability to citizens, to clients, increase accountability to the poor, both accountability of government on the supply side and accountability of providers, and doing that through both supply side instruments, mainly contracts or performance-based financing, and through demand side instruments, mainly health insurance, community-based health insurance, with a lot of voice in that as this is really community-based institutions that are managed by local groups at commune level. Results show that in a couple of years, basically in 5 years, Rwanda, which was severely off track on the MDGs, like the majority of African countries, is actually now back on track. And according to projections and to political will, is aiming at achieving the health MDGs before 2015, all of them. We see that all income groups have benefited, although inequities still persist, but we see a decrease of mortality among the poor, among all income groups. We see the coverage with MDGs-related high-impact interventions increase. The most spectacular one is family planning, because it tripled in 3 years, which is something that has never been observed ever, from around 10% to around 30%. And when it comes to assisted delivery, it increased from 39% to 52% in 3 years, between 2005 and 2007. So that's 13 percentage points in 3 years, again, something that had never been observed in Africa. Typically, as most of you know, the assisted delivery indicator is very entrenched and very difficult to move. Thinking of Ethiopia, Ethiopia has been at 6% like forever. It was at 6% 20 years ago, it was at 6% in 2000, it was at 6% in 2005. Major increase in utilization of assisted delivery is actually observed mostly in rural areas, as you can see, so extremely pro-poor, and mostly happen among the poorest groups. So that increase has happened not only by serving the rich urban elite, but also serving the rural poor. So what has happened, a few data on those reforms, look here at what happened in terms of fiscal decentralization. Government has basically transferred a lot of public money and donor money. There's been a major injection of donor funds to the districts. So here you see in blue, you have the transfers to the districts, and this moves from 2003 to 2008. I don't see the years very well. What we see is because of this funding and because of the way it was actually transferred, you see the total health personnel in publicly funded facilities has almost doubled in 3 years. And I use the word publicly funded facilities on purpose because 40% of the facilities are actually faith-based. It's 60% are publicly autonomous. So that means the government is basically having a performance contract with all the facilities, both the private, not-for-profit, and the public. And part of this money has been used to recruit new health staff. The financing for human resources has basically more than tripled in 4 years, partially through an increase of basic salaries and partially through an increase of performance-based financing. So basically people are paid both through a needs-based transfer that is sent to the facilities and is used to pay the base salary. And then there is a second component to the formula, which is a performance-based transfer, which actually tops up the salaries by 50 to 60% depending on the facility. The second part of the health financing reform was the health insurance. This is probably where Rwanda really pushed the frontier. Very few of us health economists thought a few years ago that Africa could actually develop health insurance at scale. And Rwanda basically did it, rapidly increasing enrollment from 7% in 2003 to 91 in 2008, and it's basically through a community-based health insurance mechanism that is geographically based. So you have a CBHI in every commune, and those CBHIs are associated into a national mechanism with 2 levels of reinsurance, and these levels are subsidized by the state and by donors. So it's basically between 2002 and 2008, so in 5 years, 6 years, a major expansion of health insurance. And we actually have really interesting results to show. And when it comes to reproductive health, show the importance of health insurance for reproductive health and maternal health. You see that at all income levels, we observe that those enrolled in mutuelle are much more likely to use health services. So you see that people who are enrolled in health insurance use more assisted delivery and use more family planning. They don't use more antenatal care first visit, but they use more 3 visits. Health expenditures also are much lower among the groups of people who are insured. Last but not least, innovative financing reform that Rwanda has pioneered, that is increasingly known for, is results-based financing. And here again, there's been a rapid expansion of what they call PBF, performance-based financing. There was an extensive piloting from 2001 and 2005 with basically a lot of involvement of NGOs, mainly CordAid and IntraHealth, and also the involvement of the School of Public Health. So there was a strong ownership of the Rwandese health community. And in 2005, there was a decision from the government to actually expand it, which involves working out the public finance issues that were related to introduce this kind of payment. And the objectives were really to focus on the MDGs, so to focus on maternal and child health as well as communicable disease, to increase the quantity and quality of health services provided, to increase health workers' motivation, because the idea was that this PBF would be used to provide incentives and salary supplements. So for the providers to see more patients and provide higher quality of care. So it operates through contracts between government on one side and the facilities, the health facilities providing services. And in terms of economic theory, it's basically very simple. It's basically exploiting the whole moral hazard of fee-for-service. We know that if you pay fee-for-service, providers provide more. She says, well, why don't we use that in low-income countries where we think that providers don't provide enough? So here's really just introducing fee-for-service, not for the full cost, but for the incremental, marginal shadow cost of one more unit of output, so one more assisted delivery, one more child fully immunized, etc. So here's an example. I mean, it's not an example. It's all the indicators for what we call the health PBF, and then there is an HIV PBF. The health PBF is financed by the government directly from the budget. The HIV PBF is financed through the earmark funding. So it's a nice way to actually bring together the money coming from the treasury with the money coming from the donors, which is quite high in Rwanda. It's more than 20%. It's to bring it together into one consolidated mechanism to strengthen the health system, which was to put in place an incentive mechanism and a provider payment mechanism. So here you see, in terms of maternal health, the choice of these indicators was very much in line with what was seen as what was important in terms of buying results and buying health outcomes. So there were the 4 prenatal care visits, the family planning, the deliveries in facilities, the risk pregnancy referred to hospital for delivery, the emergency transfers for obstetric care. So as you see, a very, very high focus on what matters in terms of reaching MDG5. And the prices, so I always get a lot of question on how these prices were calculated, which is basically you can use a lot of fancy word, and it says shadow price of the incremental cost of the marginal unit of output, which is basically a lot of finger in the air and let's figure out, we think this is what it should be, this is what is actually going to give the incentive. So there is some sense of what the cost of providing this service is, but there is much more a sense of providers, and we use Delphi techniques about what is it that is actually going to provide an incentive for providers to actually, wake up in the morning and say, I'm really going to get, to the village and convince the women that they need to come and deliver. And we see a lot of actually innovations and a lot of initiatives of these health facilities. And some of them, most of them have actually decreased the level of user fees in order to attract patients. They've also offered some kind of equivalent cash transfer by, for example, sewing little pajamas and offering blankets, offering bed nets. So they've themselves, there are all sorts of innovations happening in the facilities to encourage women to use the services more. And so what we see, I mentioned to you 13-point increase in 3 years in assisted delivery from 39 to 52. That 52 was actually in 2007. In 2010, we think we are at 65. The delivery at the health facility, this is the result of an impact evaluation, because as part of this, you also have a government who's very keen on actually really rigorously looking at whether the policies work or not. So as part of the expansion, there was a very well done impact evaluation done, in which, in fact, some facilities were not given the money on the basis of a results contract, but were just given the money just like that. And saying, just get the money, a similar amount, and just do what you think you need to do. And what we find here is basically we find a significant and independent effect of the contract, of the results-based financing, that actually increases the intake of assisted delivery. So that's actually the first study in developing countries that show that results-based financing actually works and can accelerate progress towards the MDGs, because the money was the same in the facilities with RBF, with PBF, and the facilities without. Just a few last slides. In the same way, not only it increased quantity, but we have evidence also that PBF has increased quality, and significantly. So you have a major increase of quality because payments are made on the basis of quantities of outputs, but they are discounted for quality. So very rapidly, the health providers realize that, yes, if they provide quantity, but when the verification agency would come and find that the quality was bad, they would actually see the amount that they could have gotten and the amount that they would get. So you would see very rapidly an improvement in the quality indicators. So let me finish by a few words about how do we get from there and what do we learn from this experience of Rwanda, but now increasingly from other countries. Burundi now, I mean, Rwanda has done RBF at scale. Burundi is going to start in April also. Sierra Leone is joining, Zambia. So there is really a movement right now in Africa towards results-based financing, also towards insurance, as ways to make financing work better, both for the MDGs and for the poor. So we know that the MDGs were and are ambitions. We know that scaling up is challenging. But we know that the SSA countries don't have a lot of money. They need more money, but better money that is better allocated domestically and more external funding. But what we've learned from the high-level task force on innovative financing that published its report last September is that, in fact, most of the countries are to come from, most of the money is to come from the domestic funding. So, of course, the high-level task force put a lot of emphasis on new external money. But if you look at the data of the projection, you see that, in fact, most of the money is to come from increasing allocation of governments to health. And this is what the dialogue should be about with ministers of finance. So there is a need for domestic advocacy to raise attention to national budgeting process. But what we see also is half of the money is actually private and out of pocket. So we also need to have this conversation about channeling private spending into risk pool. So the health insurance agenda is no longer an agenda for middle-income countries. Rwanda and Ghana also have shown that it's an agenda for poor countries too. And for the role of external aid in that has to be catalytic. There is a need to focus on results and efficiency gains because external aid only brings marginal money. But so the money needs to help the domestic money work better. So if we think about the evolution of health financing system, we think that, in fact, in Africa, we could probably go faster than middle-income countries have gone through, because we can probably make some insurance models work better and faster. As out-of-pocket spending has been growing recently, we more and more have countries that have 70%, 80% of their health expenditures being private. The need for pooling emerges as a main policy priority in sub-Saharan Africa. And we have these two countries now, Ghana and Rwanda, which are achieving quite groundbreaking success on health insurance and are pushing the limits of the innovation frontier. And results-based financing, so that's sort of the other innovation. We purchasing of results, output replacing input-based financing. We really have promising results. We have this study done in Rwanda, which is really giving us a lot of hope in the way it shows that results-based financing can really get us to have the right indicators faster and in a way that is actually sustainable because it's financing coming from government. And in conclusion, when we're talking about maternal health or any other MDGs, a strong dialogue between MOH and MOF is more needed than ever. And we advocate increasingly that the dialogue should be centered around the production of results. We need to say that the health sector can do it, that it's not just trust us, health is important, just give us money, but look, we can actually deliver results. And in Rwanda, it has worked beautifully, as you've seen, because the more the government see the results, the more they allocate to health. And you see the budget for performance-based financing of insurance increasing year after year. Thank you very much.
Well, terrific. Thank you, all three of you. With very rich presentations, I think quite complimentary, and give us a lot to think and talk about. Why don't we go straight to the Q&A? I have colleagues with microphones. If you could wait to use that so the folks online can hear your question. If you could tell us who you are and pose a nice, concise question, that would be terrific. I think because I'm sure there will be a number of questions, perhaps what we'll do is get 2 or 3 or 4 of them and then give the panel an opportunity to divide and conquer in responding to them. So who would like to kick us off in terms of the discussion for this afternoon? Okay, question down here.
Chen, freelance correspondent. You give a very good presentation. My question is this, what the source of public money and the private money? Thank you.
Okay. Okay, well, like I said, why don't we capture a couple? So, down here, Michelle, in front.
John Townsend, Population Council. The question is, these are promising models, but is it enough? When we see curves that go up to 50% of people get good quality services, what do we need to get to continue that trend? Mexico has a longer period of review. Africa has less. The question is it enough? And in some countries, there's been a tradition kind of faking some of this performance space. In the family planning area, that's been well documented. The question is, what's the role then of external agencies in reviewing progress and the consequences of health systems, information systems that are inadequate to do the task? Thank you.
Okay. And Charlie Teller over here, and then we'll come down here. So, Michelle, right up there.
Wow, these were 3 great presentations. I think we can learn a lot from Rwanda, but we can also learn a lot from Ethiopia, as was mentioned, as to why the access to ANC has stayed at 28% and skilled birth attendance at 6%, and post-natal care is basically 0. I think the approach, the diagonal approach, is really the vision to look forward. I would like to ask if Julio could add a 5th concentric circle and add women, health, and development. Because we're finding that development, and particularly with the increased urbanization, unemployment rates among women are the highest, much higher than for males. But I'd like to contrast that also. A second point is that one of the reasons that in Ethiopia the ministry says that there's been no improvement in maternal health has been the recent focus on emergency obstetrical care, that a lot of the focus has been on the tip of the iceberg, and where most of the population, though, is not into the system, so they cannot benefit from the EOC.
Okay, terrific. Yes, Gail? Okay,
I'm Georgia Sambanaris from USAID. I'd like to thank the panel for your excellent presentations to commemorate Women's Day. My question deals with how appropriate is it to use cost-effectiveness analysis and cost-utility analysis in using health economics to assess cost interventions for maternal health? Because it seems that you're looking a lot at clinical indicators, and there's a growing segment of health economics that's costing out donor resources to scale up to address diseases. And my second part of the question is, I thought that fee-for-service didn't necessarily correlate to quality of care. And I'd just like your response to that.
Okay, that's a rich batch of them. We'll come back for some more, but who would like to kick us off for a discussion responding to those? Yeah? Go ahead. Don't all jump at once.
We're very courteous here. I mean, on the first point of if I understood the sources of of external and I mean of public and private money. That was your question, right? You know, all money comes from people, and the only question, people working. The only question is, when it comes to health financing, whether that money is paid at the time of using services or before, and whether whether it's paid in a way that protects you against risks or not. That is to say, whether the money gets pulled together in so that then it can be expended when it's required, independent of the episode that triggered the use of the money. So the basic issue here is, as was shown, I mean, in most developing countries, the main source of money is private money from individuals paying at the point of service, rather than individuals contributing taxes through an efficient system with a government that represents their interests, that then uses that to fund a public system, or individuals paying premiums that then go into a pooled insurance scheme. And what that reflects is a sort of a lack of either organization to separate the moment of paying for care from the moment of needing care. The best, or let me put it that way, the worst way of financing a health system is relying on out-of-pocket payments where people pay at the moment of utilizing services, because it's both inefficient and it's unfair. It's unfair because it makes the sickest pay the most. And since most illness is not the fault of people, it's an inherently unfair way of financing a system. And it's also inefficient because it doesn't take into account the key attribute of health events, which is uncertainty. Since none of us knows when we're going to get sick or have a serious accident, the best way to finance a health system is to separate the moment of contributing from the moment of using services, and to do that in a way with as large a pool as possible, and in a way in which that contribution is proportional to your income or your means and not to your needs, not to how sick you are. Because it is ethically defensible to contribute differentially according to your capacity to pay. It's ethically indefensible to make contributions depend on how sick you are. So that's a... I think that what has been missing in this country, and a reason why there's no health reform, is because these principles, basic principles, have not been debated publicly. What do you think is what anyway? I'm not going to get into more trouble. On John, I want to stress your point. The only way and I'm sure Agnes is going to agree with it, but the only way to have results-based financing is if you have external verification of results, because the incentive to, let's not call it cheat, but the human tendency to overestimate your could get you. So if you don't have independent verification of results, it's very, very difficult to get the results. So I think that's an excellent comment. I couldn't agree more with the idea of the fifth circle and the connections with the larger development agenda, but particularly with both ways of in which better health affects development and vice versa. I think one of the strong points we need to make is that investing in women's health is probably one of the most effective ways of improving general income. These issues that we were talking about catastrophic expenditures, it's a human drama. It's also very bad for the economy because poor people end up liquidating productive assets. They end up taking children out of school to get them to work to pay medical bills, with all the effects that has on the accumulation of human capital. So making those connections explicit, I think, is a great idea. And then lastly, I agree with your point about the limits of cost effectiveness. as such, in the Mexican health reform, in defining the benefit package, the law explicitly says that the criteria will be cost effectiveness and social acceptability. And the reason for that is that if you just use cost effectiveness per se, most cost effectiveness analysis assumes constant marginal cost. But in point of fact, it ends up being always more expensive to reach the poorest people, the people who are furthest. So, if you want to bring electricity to a remote rural community, the cost to do that is several times larger than to bring electricity in an urban area. And the same way to deal with, to offer health services. And this is particularly critical in the area of maternal mortality, particularly with the problem of obstetric emergency. So I think adding the component of social acceptability, including equity considerations, where you may be willing as a society to have not the most cost-effective, not be on the absolute curve. I let the economist explain to you those concepts better, but actually to pay a equity over price, if you will, which is not an inefficient use, it's just an equitable use of resources, I think is entirely valid. Because otherwise what happens with pure considerations of efficiency is you systematically exclude the people that are hardest to reach, that have the least empowerment to actually take care of their own health, et cetera, and then you just perpetuate the cycle of inequitable allocation. So getting that balance straight is a trick. The good news is that there is a huge area where the most cost-effective interventions also benefit the poor disproportionately, and it's that area that we need to exploit. And reducing maternal mortality is exactly one of those. We have very cost-effective interventions because this is the most inequitably distributed health indicator in the world. If you focus that as a priority, you both achieve efficiency and equity simultaneously.
Thanks. Just a few words to add. I want to pick up on the question of what more do we need to do. And I would say that, within this context of looking at results-based financing, and what do we want to monitor, I think a key aspect that we're also increasingly concerned about in this context is that of quality. And we've seen some very rapid results of increased institutional deliveries in some of the schemes in India, where there's some very deep concerns about the quality of care being provided. So that it's one thing to have institutional deliveries, it's another thing to make sure that those are well attended and that the quality of care is there. So I think there's an enormous role for external agencies to be looking at that, but also to be building that into a system that is monitored. And then to come to and I will come to the Ethiopia question in a moment, but also to link this to this correlation around, this whole issue around cost effectiveness in maternal health. I mean, for too long, addressing maternal mortality was seen as too expensive, that we would do things in the cheap way, and that's why we had loads of traditional birth attendants. And certainly in Ethiopia, had the development of the thousands and thousands of health extension workers who now, it's acknowledged, are not going to provide the kind of health impact that was hoped for. So I would say I think we also, within the maternal health field, have to be a whole lot smarter about figuring out what are our outcomes if we want to do costing and cost-effective measures. So, how do we attribute strengthening a health system for maternal health improvement? And what impact does it have on other health outcomes, like accidents and emergencies? You've got a better system there, and it's one of the biggest, sort of increasingly largest sort of contributors to the DALYs. So, I think that we've just got to be better at figuring out how to do this. Child health has done it remarkably well. We're just a little behind the curve when it comes to some of these. But also we've always said that to address maternal mortality means you have to take on the health system and, really have to grapple with it. It cannot be delivered solely in the community. And I think that comes to the sort of notion of, what's going on in Ethiopia. And really within AMDD, we often sort of have the saying of there's a whole lot of stuff that we can do. And then there's Ethiopia, which just really challenges us to the limit when you can't, even the health extension workers, the traditional birth attendants, cannot even get access to women at that moment of delivery. So even those things that you may be able to do in the community that would certainly improve the life of newborns, you're only seeing those newborns 2 or 3 days if they survive after birth. So I think that there's things that need to be done simultaneously, and that it's not an either or. And certainly, you know, we have very close links with the Minister of Health, and in our sort of last contact with him, I think there is a recognition that lots of things have to be happening at the same time, that it's not just about emergency obstetric care. It's not something we don't sort of say it's all about emergency obstetric care. We believe that there's a continuum. We believe that we just have to figure out in each country what's going to work and where do we start. It's not a cookie-cutter approach. We can't say here are the 10 things you must do and you will have success. It's going there, increasingly looking at new ways of new systems thinking, ways of how do you figure this out. But what we do know is the kind of shortcuts and the kind of use of ineffective mechanisms. Deborah Main, many of you will know her, used to say you can't talk about cost effectiveness of an intervention if it's not effective. TBAs were certainly not effective in reducing maternal mortality, as an example. So I think I'll just leave it there.
Okay, I'm not sure there is much more to say. Just maybe a technical point on the difference between private and public expenditures. I mean, it's very well defined as part of the National Health Accounts methodology. So basically what you consider public is any money that goes through taxes and levies from government and that are spent by government. And private is the money that doesn't go through this channel. So it's contribution to social insurance, contribution to community-based health insurance, contribution from employers, employees, financing from non-governmental organization that they do through their own fundraising. So we take all that into account, but mostly, as the data show, and as said by Julio, is mostly out-of-pocket spending that actually dominates in most of the low-income countries. It's actually what people pay. So there are very little contributions from employers because the formal economy is very, very small in those countries. On the issue of cost effectiveness, I think cost effectiveness is an instrument. It's not an objective. It's an economic instrument that can be used and misused. And I think the point of cost effectiveness, it's an instrument, it's a tool for governments it's a technical tool to make decisions. But it's not the only tool, and there are a lot of other criteria. It's basically the key question boils down to what it is that the collective purse needs to do. And this is mainly a democratic question. It's about collective action. It's about countries together deciding what is it that government should finance. And cost effectiveness is a very important tool to try to have an efficiency of public expenditures. But you see that different societies make different choices. It's very clear in Europe, where you have almost universal social insurance or tax-based insurance, and you see countries making different choices in terms of cost effectiveness, because there is also, taking an example is palliative care. This is what is socially, social acceptability, what is socially acceptable. Palliative care is often seen as something that's not particularly cost effective, but is a society ready to accept that people die, palliative care for a destitute, that they will die on the street? I mean, most societies will think it's not acceptable, and the collective purse needs to pick that. So I think we're very, very aware, I think more and more, that we need a much more broader set of instruments if we want to look at the issue of financing. So of course on results-based financing, yes, verification is key. The moral hazard is a very, very hard law, and cheating is the word. It's called gaming sometimes, but I think this is what it is. This is the first thing you get when you start to pay for results. The first thing you get is gaming. Our experience, however, which I sort of wanted to share, is that the verification mechanism in itself is an extremely powerful instrument to improve health information system. And that's what we've seen in Rwanda and elsewhere, is many countries have invested in health information system for years without much to show, frankly. And it's very interesting, you see, the moment you start paying people on the basis of the health information system, wow, that gets very interesting. Suddenly people get very interested in the health information system and filling forms and making sure they're filled properly. If your salary at the end of the month depends on it, suddenly this becomes much more interesting. And you see, really, I mean, for me, that was an eye-opener in Rwanda, how the performance-based financing, if one thing it did, is a major quality leap in the health information system, in the quality of information and in the interest that people take into that.
Okay, so do another round of questions. Yeah, right. Go down here, and then Liz over there, and then down here.
Hi, I'm Anne Blank from the Maternal Health Task Force. I have a question about Rwanda. The natural question that arises to me is how could that model be replicated in other places, since it seems to be so effective? And I think that the mechanics of kind of how you put results-based financing in place and how you do health insurance are sort of known. But to me, the question that's not known is where does the political will come from? And that's obviously a necessary precondition for all this to happen. And so I guess my question is, what happened in Rwanda? I don't know the story particularly well, but it would be a shame if it was idiosyncratic, if it depends on an individual. Is there something systematic that we can identify that increases the chances that the political will be there to do something like this?
Okay, thanks, Anne. Liz Schenecker.
I'm Elizabeth Schenecker from USAID, and my question is almost exactly the same for Agnes. So let me just say it slightly differently. Could what happened in Rwanda and the success that you described with performance-based financing happen almost any place else in sub-Saharan Africa? Or does something have to occur first? Do you have to presuppose a certain level of good governance or a certain level of an effective policy environment or something else? Okay. Why don't we try to capture these last two real quickly and then give our panel a chance to wrap us, please.
Okay. Hello, my name is Lynn Franco. I work for a university research company in the Healthcare Improvement Project, so I'm going to ask a QI question. We've looked a lot at how to create some incentives in terms of generating demand for care through social health insurance or trying to create incentives in the system to produce services in the way that we want. And I'd just like to ask about what role quality improvement might play, or you see that playing in terms of health system strengthening, in terms of ensuring that the services that are being used or the services that are being provided are actually going to achieve the results that we're trying to get.
Okay, great. And then Kaylin right there in the middle.
I'm Nancy Sloan with Columbia University. I'd just like to know if Julio would reconsider the diagonal for something more synergistic and multidimensional. I listened to the talks today and think if we save the newborns, we can also save some of the women. If we improve institutional delivery rates, we also improve skills because providers who service more women continue and maintain their skills better than those who don't, and so on. So I'm just wondering if there's a little opening for some multidimensionality. I realize the diagonal is nice and neat.
Shall we start with the Rwanda questions?
Yeah, of course it is the question. There are a couple of dimensions that we can talk about to respond to this question. I mean, first, I think there is no question, everybody who knows Rwanda a little bit, that it's an outlier with an amazing leadership, particularly leadership of President Kagame. It's also a country that is in many ways unique in Africa because, in fact, contrary to what people think, it's a very homogeneous country. It's one language, same culture, same religion. So although people think because of the genocide that it's an heterogeneous, not at all. It's extremely homogeneous. It's a country that has a very long history of nation state, which is also very rare in Africa. It's a nation state and a very strong history of top-down control with very strong leaders, kingdoms, army. It's a military society. So it's certainly a society of order, very authoritarian regimes over the history. I'm not particularly the last one, all of them, very authoritarian. So really you have definitively, if I go back to I refer a lot to that triangle of accountability from the World Development Report 04, you really have this compact, you really have a central government that controls its people and control its providers. And that plays in Rwanda for sure. Leadership is terribly important. I mean, it's the way the IMIGO has been developed as a contract. I mean, there is nothing, we can say that would deny that. However, I would like to make 2 points. First is, yet Rwanda is not successful on everything. Rwanda has also a lot of failures, as we know from the past. Rwanda is very good at, because it's very top-down, very command and control, is very good at choosing a way and going for it. We've seen that in '94. It's not always the right way. So they also make a lot of mistakes. And they've done a lot of mistakes in the past. So they're very good at implementing, but they're not, there is no particular miracle in actually choosing the right policy. And we see even between sectors, the health sector has done incredibly well. Not all sectors are doing very well. You have sectors that are not, and I'm not going to, point fingers there, but there are sectors that are not doing well in Rwanda. So that's, if you want to have a comparator point, it's not that everything that this government does, is gold. The other point is really about the replicability. And to my mind is, if we think about the Rwandan model as just the Rwandan model, yes, you have a problem of replicability. But if you think about the Rwandan model as the triangle, then it's highly replicable, because what it does basically, and I try to emphasize that, it tries to go for accountability. So accountability can go different ways. It could be accountability from providers to government, that's a typical command and control, but it can also be accountability of providers to communities, to citizens. And that's very much the way the community-based insurance works. The community-based insurance, in fact, has very little to do with the government. The government started subsidizing it only last year. Until now, this was completely funded by the people. And it's completely managed by community associations. So there is really this adaptation in terms of the thinking that needs to be made in other countries. But to my mind, this is the model, the approach of strengthening accountability, either to the users or between government and providers. This is what the model is. And that model is extremely relevant to other low-income countries, and particularly to low-governance countries, even more appropriate than in Rwanda, in the sense that here in the low-governance environments, you're really looking for models of accountability of providers to citizens. So you may want to go really for demand-side financing. You also may look at, in failed states, for example, or in fragile states, you may look at the possibility of having NGOs running services with contracts based on results-based financing, a bit the way Afghanistan does it. So we also have evidence that results-based financing work in this kind of low governance environment. And interestingly, the other country that is just moving full scale on results-based financing is Burundi, which, as you probably know, has a completely different governance environment. It's really a very pluralistic society with a kind of, much less command from the top, and quite serious issues with governance. But what we can see in the Africa region is that results-based financing and health insurance, to be a bit blunt, is a way to provide alternative models to what is seen as the sort of failed models of the past. And why are they alternatives? Because they build accountability. When it's insurance, it's because, say, well, the tax-based system, financing, the government system has reached its limits, so it's not working. So why don't we create another institution that is going to be actually making the payment? It's not the social insurance in terms of employers contributing, because this is not happening. You just don't have but it's social insurance in the sense that you have a third-party payment. So you try to have some kind of accountability. And that's the same with results-based financing. So we can even envision models in which, in fact, the purchaser could be an association of citizens or a major NGO, not necessarily the government.
Helen, can you tackle the quality question?
Sure. I think that, as you know, I mean, quality improvement and the extent to which that can be successful in strengthening health systems also goes to really how the whole process is located within the health system. So, and what authority and what flexibility do people at the various levels who are trying to respond to whatever audits or whatever assessments they do of quality, what capacity do they have to actually make the change? I think that what we often see is that there may be quality improvements processes in facilities in many of these countries at the hospital level, at the health center level. But then when it comes to how action can be taken, there is some action that can be improved, certainly. But the kinds of decentralization, for example, that we saw in the Rwanda example, where there is some flexibility on how monies and finances and resources could be brought around and moved around, doesn't exist. So it often ends up in quite a frustrating place. So I think that the one is that certainly quality improvement is a core part, and quality assessment is a core part of what these health systems should be looking at, particularly as we see from a maternal health point of view, is that women in many cases make the choice not to go to poor quality health services, particularly to deliver. They'll go for antenatal care in droves. We question the quality of that in itself, but when it comes to actually delivering, they choose not to go because they're not going to get anything. So I would sort of swing it around a little bit and say, how can we use quality improvement? How can we use any of those kinds of systems of looking at quality to strengthen the sort of accountability where communities become more involved in monitoring and looking at what's going on with quality in the services? What are those mechanisms that are available? And ultimately, this takes the kind of leadership that says when we will respond to whatever comes out of those assessments. So the extent to which governments can take up the quality issue and respond signals how important some of this is to how important they see maternal health and the strengthening of health systems to the population. So, I think it's obviously a core part of what needs to happen with health facilities, but it requires that action can be taken, and maybe we use it as a good place to strengthen the accountability piece.
Terrific. I'm afraid for time we'll give Julio the opportunity to have a dialogue on what's exactly the right shape and form for capturing the synergies of diagonals, but we've gone over, and I think it's understandable given how rich the presentations have been. Some excellent questions. So please, won't you join me in thanking our panelists for this afternoon's discussion?